Hello, everyone, Vascular Cures community. Welcome to our very last Vascular Innovation Series panel discussion of the year. This series was intended to bring together content experts and thought leaders and patient advocates around various topics related to patient centricity and vascular healthcare and research. Today is a very special session because, as you all know, this is the kickoff to our annual meeting and gala, Circulate, which is streaming live later this evening. We welcome you to join us for that fun experiment that should be should be interesting for everybody. But that's also why I'm in my party gear and not my professional attire. And the theme for Circulate this year is Power to the Patient. And so we thought it would be really interesting to talk about the large-scale impact that patient empowerment can have on health outcomes with an eye towards prevention. And I'm really excited about the panelists that we have here today because I think they all bring a very uniquely distinct but meaningful perspective to the discussion. A couple housekeeping things. Everyone here participating is on mute and we can't see you. This is not because we don't trust you, but just to give our panelists full visibility. This is going to be more of a conversation than a formal presentation. And so I welcome questions throughout the discussion. So please enter those in your chat or Q&A functions on your menu bar, and I will do my best to introduce those to the panelists as appropriate. I am gonna stop talking and hand it over and ask that each of our panelists introduce themselves, and as they do so, give our audience a little bit of context in terms of your background that informs the lens through which you look at this topic, because they're all different, as I said, but very interesting and applicable. And what better way to start than with our very distinguished moderator and board member, Kevin Heath.
Thanks, Megan. Yeah, so good afternoon and good evening, everyone. I'm Kevin Heath, and I am a nephrologist, so I'm a physician by training. I'm a medical director at Optum, where I lead a team of clinicians and operations folks, and we are called Clinical Intelligence, and we do research, and we do education strategy. And so I've been engaged in some vascular research, largely around peripheral artery disease, working with Aruna, who is also here tonight, on a number of those projects. And thank you for having me.
Great. Kevin, maybe I'll just go next because I'm on the screen. My name is Aruna Pradhan. I'm a cardiologist at the Brigham and Women's Hospital in Boston. I'm also an epidemiologist and a clinical trialist. I was the chair of the American Heart Association's Council on Peripheral Vascular Disease, and I serve as immediate past chair this year. My focus is really data, population data, clinical trials into aspects that address screening and the appropriateness of screening, who to screen, and potentially also demonstrating that early detection improves long-term cardiovascular outcomes. So I'm really happy to be here with you guys.
Yeah, thanks. I'll take a moment to introduce myself. My name is Jason Belzer. I'm the Divisional Vice President of Sales and of Marketing for the endovascular division of Abbott. And I also hold a master's in healthcare economics and patient outcomes research. So Megan, you know, the lens that I view this through is sort of twofold. When they let me sit at the table and have smart conversations around healthcare economics, that's certainly something we spend a lot of time and energy thinking about. How can we design trials and collaborate with esteemed physicians like those joining on this panel to put together trials that are meaningful. And then also I do view it through a commercial lens. As a sales leader for a medical device company, we always try to understand where we fit in this process and how we can add value to who we consider our customers, which are both the physicians as well as obviously the patients in this situation.
My name's Steve Hamburger. I actually have a number of clients, but one of them is firm called Shockproof Training, where I work as the chief marketing officer. I've marketing background and been in marketing for over 40 years in the financial services area. I am been a patient advocate for Vascular Cures for about 4 years. I was originally diagnosed with PAD about 10 years ago now. Seems like an awful long time ago, but and in that original diagnosis, the surgeon that I was with suggested that I might do a bypass. Luckily enough, I went and got a second opinion with my vascular hero, Dr. Willis Wagner at Cedars-Sinai, who suggested that I might try a walking regimen to overcome my PAD. And luckily enough, I've been able to institute that exercise regimen and avoid any surgery at this time. And I look forward to continuing being a patient advocate for Vascular Cures.
All right. Thanks, everybody. Let's kick it off, because there's been a lot of discussion here about, even in the introductions, we're hearing about outcomes and, you know, Steve, your story about getting your second opinion. And so I think the first question I'd like to ask and just bring up for discussion is, you know, how do we really engage the patients, and when should we be engaging the patients, especially when we look, you know, from a population health perspective? When and how do you think?
I might take that initial question. I mean, it's my strong belief that we are entering an era in which we are understanding the biology of peripheral artery disease much better than we've had previously, such that we have some emerging therapies that could be instituted, and these are medical therapies that could be instituted very early on, as well as what Steve had alluded to, the supervised exercise therapy that could really change the trajectory of this disease. So from my perspective, I think that we should start engaging patients who are high risk and talking about screening early on. That's the time point in which we have probably, but not proven, the best chance of changing the lifetime risk of patients with PAD.
You know, as a patient, I would really support that. I have been doing some social media work for Vascular Cures, mainly on LinkedIn initially, and joining groups all over the world, you know, with regard to getting the word out on PAD with regard to Vascular Cures. But what I also did just recently over the last 4 months was join a number of Facebook groups where you actually have the patients involved. And what I've really been struck with is how far along people allowed their PAD to progress, and the different questions that are being asked. But it's, you know, to me, the importance of getting advice early and being diagnosed early and being able to have options given to you, or second opinions, like in my case, you know, to deal with what really is a complete change in lifestyle. I believe it's not only has to do with exercise, but it has to do with diet, it has to do with medications. There's a total issue of providing the patient with information, I believe, early on, you know, in the disease. The earlier, the better to me, because I really do believe you have to be able to make the patient aware of the different things that are available to them, but also what can happen if they don't take action, just based on the severity of the what I'm seeing online in the different Facebook groups with regard to PAD.
Yeah, it's interesting. It's almost like we need to capture the patient and integrate them in the solution before they're the patient, right? We understand the risk factors. We understand, smoking and hypertension, and these things contribute to all these things. It's really about getting to the patient and empowering them to prevent themselves from being the patient. And we think about it from a healthcare perspective. We think about ACOs, right? ACOs were developed to help facilitate coordinated care really throughout the entire continuum of care. And, part of that is improving the patient experience. And you'd expect a really strong correlation between increased engagement from a patient perspective and that improved experience. So it's really about, I think, the education piece that you just hit on, Steve, along with, assessing the risk factors that Aruna, you mentioned, that those are really critical elements to this, I think, from an economics perspective.
So I'm curious, kind of following up on the last two comments, Jason talking about the need to identify the patient before they are the patient, and Steve, your comment about your words, I believe almost were, it was amazing, or it is amazing how far these patients let their disease progress. And where's the disconnect? Why is it that the people who seem to work in the healthcare space can see this, yet the patients, we're hearing comments like it's amazing how far the disease progresses before they do anything or before someone does something. How do we bridge that gap, I guess?
Well, I'm hearing a couple of comments coming through on the chat. It sounds like from David Armstrong, for instance, it's getting patients to talk to each other, that perhaps the voice coming from a physician may not be enough motivation, that we should be using some of our more modern approaches, technology and social media, to get patients more engaged. Most of it, I'm actually not sure how to do that. David, I'm not sure if we can unmute you, but are you doing that in your practice now? Are you getting patients to engage as a provider, getting patients to engage? Or is this a role better served by organizations like Vascular Cures?
Yeah, while we're waiting to see if Dr. Armstrong can jump on, I think the other piece of this is the technology, right? As we've entered into a world of increased wearable technology that is tracking so many different things, what role should that play? If Steve's got a wearable technology device, like for instance, my wedding band, is a piece of wearable fitness technology that checks all sorts of different stuff. What role should that play in terms of communicating with physicians or with the potential patient as well, to understand whether or not, they should be immediately funneled into some sort of informational pipeline.
And I just want to call out this comment from Doug Gray, because I think it's relevant when we're looking at, where are the disconnects. And he points out that there's kind of this disconnect between what we know to work, what's been proven to work, and what's reimbursed, right? And so that may cause some confusion in terms of, what's available and being, advocated to patients in terms of care and treatment options. And I think the other thing I want to comment on, and this has just been, our experience as an organization working with patients, is it's really uncommon that people get the right diagnosis right away. So, we say patients wait too long, but really I think it probably has more to do with care providers, right? And the lack of awareness, at a GP level, probably specifically around the risk factors for this condition. And, one of our patient advocates had about 6 different misdiagnoses before coming to PAD, including restless leg syndrome and anxiety. And unfortunately, I think that's common, right? I want to say that's the exception, but I think it might be the rule. I'll stop there.
No, and then I'm noticing here, Mike makes the good comment about how, it has a very, vascular disease has a long preclinical phase. And so I guess that was going to be kind of another question, is when, because when we talk about prevention, I think far too often we talk about how to prevent an amputation when disease is already very severe, when we should be at a point of saying, let's talk about how we can prevent disease from becoming severe, right? And so when, I think that's a question that I have, again, about, when to engage, when do you engage at the primary care level? Is that where we need to focus? Because, by the time you get to the interventional cardiologist or the vascular surgeon or whomever, you're more likely to get a procedure, I would think, right? I don't know, thoughts, comments?
In a perfect world, and I also think, in a future world, your primary care physician should be linked up, for example, in a Kaiser world, I can communicate, everything is there online. My test scores, being able to order, any medications, etc. So, I'm completely linked up in an online world. I think to me, the future is kind of what we just kind of talked about here a little bit, where you've got wearables that essentially are providing all forms of all forms of health measurement, if you will, anywhere from physical activity to blood pressure to, futures glucose readings, that you're then able to, for example, for my cardiologist, I provide with one of, the apps that I have, I provide, before I see them, I provide them with 2 weeks of blood pressure readings, and I can, pull that down and I can now, print that off and essentially send that to them in a Kaiser world. So they've got that measurement, if you will. So in futures, I kind of view that you're going to have your primary care physician is going to have all these ways to understand your health condition, but more importantly, what you're doing about it to essentially deal with it. And then, again, I'm being an advocate for, the activity, increasing your exercise and diet, and the medication, and that all having an impact. But I really believe that needs to be early on. Sorry if I'm taking too long, but.
No, Steve, what I'm wondering is, who's the best able to interpret that data? I mean, so there's so much data coming back from these wearables. As a busy cardiologist, I may not be able to look at all that data, and whether we need intermediaries that could do that, vascular specialist nurses or other providers.
Well, I think the future of the app is, the app is going to do that. I mean, today Apple talks about Apple One, which is combining all their different, apps, if you will, or services into one. I think futures, you're going to have, you're going to have an app that's your personal app, that's your health condition, that's going to provide all this information, and then be able to provide it to, let's say, the cardiologist or, your primary care physician. I'm just maybe talking too much futures, but.
No, I hear you. And I think it touches upon something that Ed, you is mentioning in the chat as well, sort of who is the curator of the information that should be disseminated to patients and providers. I mean, who develops that app and says, you should be, you should go from a statin to a PCSK9 inhibitor, or, what are the what are the appropriate next steps? Who should be advising you and providing that guidance? And as Ed mentions, who should be providing prevention and education measures? Again, I'm not sure if Ed can come off mute here, but who really should be driving the education and awareness? There are a lot of us that wear these hats. Is there a way to get the community to work together? Is there a single lead that could do this, or are we too divided to make that work?
Yeah, this is Ed. Can you hear me?
Yeah, Ed.
Hi. Thanks for the cue. I would agree with you. I think we're terribly divided. That's why Vascular exists. We have a mission, but one clue, and I'm not sure it's the answer, but one clue is that, to get ourselves out of this chicken or the egg problem, which is, if we actually did the work to demonstrate clinical benefit by collecting and analyzing the data, then we could get reimbursable therapies paid for. But that work, to do that in itself requires capital. And there's no one player in the current established health ecosystem does that, with the exception of possibly venture capital. So one of the potential silver lining is that because of COVID-19, the rate of growth in the digital health tech market is growing at 20 to 30% CAGR, and it's upwards of $30 billion. So there's a lot of money that sits there, but what these investors will look for is, of course, a financial ROI. So I guess what needs to happen is that we think it's worthwhile to direct some of that digital health investment towards a solution that helps with PAD prevention and awareness. That would be interesting, but I think it comes back to you all as experts, because they would look to you and say, what do you think would be a worthy app, or what would a potential solution look like that you think is really worthwhile to invest in? Noting that there are no guarantees, of course.
Yeah, and just through a commercial lens, because we're certainly not necessarily in the technology space, but we are in the commercial space looking at this. I think you raised some really good points, because one of the big challenges here is, FDA, for instance, has set up an environment where most of the trials that we run are not necessarily what you would consider real world collections of data. And I think, that's a challenge in all of this, because it doesn't necessarily give us the sort of output that we need to best assess these patients. It's the situation we're in, but really real world evidence becomes, I think, of paramount importance here as we try to assess this, and integrating all this new technology is something that I can tell you as sort of an old world, brick and mortar med device company, we really struggle with. We're not sure about some of this stuff, even who owns that data or how to compile it, et cetera. And I think, from our perspective, we do see that we have a role in some of the education and awareness, but it's not necessarily through Abbott or Boston or Medtronic, but rather, through the physician, and what can we do to help facilitate the spread of this important information through the physician portal as well. So I think you bring up some really strong points. It's something that we, from an industry standpoint, we really, I think, struggle wrapping our arms around sometimes.
Great. I have a question here from Julie Thompson. She said, and this goes back to awareness from a provider perspective. She said, patients need to be made aware by the GP. You're told about menopause, heart disease, and you should be told about this too. And I think, Kevin, you and I talked about this in preparation for this discussion about how can we shift how we have this conversation. And I would love if you could just take a couple moments and comment on that.
Well, one of the things I've been thinking about, and I'm interested for the others' comments as well, is, we get to be very metric driven in primary care. where there's a target A1C in a diabetic, and there's a target blood pressure. And patients hear all the time, you need to control your blood sugar and you need to control your blood pressure. But they may or may not necessarily think about why. What's the significance? What's the significance of controlling the blood pressure? Or, one of the things Megan and I talked about was cigarettes, smoking habits. People always associate smoking with what? Lung cancer. You know what? Smoking gives you vascular disease too. But I think, I know from my experience, I'm sure every healthcare worker in here, in this group, has had patients who said, I've smoked for 60 years and I'm fine. And then they've had 4 heart attacks and they have lower extremity vascular disease, but they don't have lung cancer, right? And so they're fine. But so how do we get that conversation? How do we shift the conversation to the primary care, to the office, to the clinic?
Yeah, I think one of the things that we as a vascular community need to do is to maybe get away from the mortal events, the death due to cardiovascular disease, but focus more on the quality of life and things you can't do as a result of progressive PAD. I'm not sure that we have perfected that argument because the symptoms are often associated with just getting older. And what would happen, how much better would your quality of life be absent PAD? I do think that's an area that we need to spend more time on. What does it mean to live with PAD?
Aruna, do you do outreach to your general practitioner or podiatry community in your area around PAD awareness? I'm just curious.
No, not really. I mean, what I've done is I co-chair along with Amy Pollock the PAD awareness task force at the American Heart Association, and what we've been doing is trying to get together, probably many of you on this webinar today, to come up with the sort of the cherry on the effort is to come up with a national PAD action plan, which will try to further awareness amongst primary care physicians, amongst patients, amongst policymakers. But on an individual level basis, I mean, my practice is at the VA, so I see a lot of patients that are polyvascular, that end stage, and it's really primary care is not the issue.
Yeah, we still see it very much grassroots around the country in terms of, and I get it, at a VA setting, that's not necessarily the model, but at a community hospital setting, what I see when I'm out working with physicians or with my team is very grassroots. It's setting up meetings with podiatry, like Dr. Armstrong, and going and educating, not that Dr. Armstrong needs it, but going and educating on some of the early signs or what the referral pathway should look like. Same thing with general practitioners. And it's a painstaking process. And again, speaking from a commercial lens, we're very committed to trying to share the information, but also staying agnostic to making sure that everybody's got access to it.
Yeah, and I'm actually going to see if Dr. Armstrong wants to comment, because something we think about, I always think about who's owning what in vascular healthcare, right? And I don't feel like there's anyone currently owning that best practice, dissemination with a specific focus on prevention. And David, or if you're available, maybe you just want to, I guess, follow up on your previous comment if there's anything lingering there, but also comment to that piece, because I think it's part of what ALPS is trying to do.
Yeah, well, sure. Well, by the way, thanks for having me. And boy, this is a freaking great panel. I mean, we could do this all day. I know you guys would want to have some sort of digital restraining order after all that, but there's so much to develop here. But from my little end at the end of the body on the anatomic peninsula in the foot, I'll just say that well, Megan just sort of teed it up there in that I think what we've been identifying here as the four of you have been talking kind of Brady Bunch style there, it's that you know, there really is not a sort of limb preservation specialist or limb salvage specialist. I mean, there are skill sets right now that exist around the world to manage this, obviously with the patient at the center, with industry involved, but with various physicians and surgeons and other kinds of therapists. That has really, and we see that Vascular Cures has been a major advocate for paying attention to the periphery, but it's part of it. It's the, you know, it's the flow part, but there's a lot of other stuff. And what that's led us to do very recently has been to say, look, maybe what we need to do is to create a format to where we can bring everyone together that really cares about this problem. And that has led us to what we're now calling, just kind of launched a couple of weeks ago, called the American Limb Preservation Society, or ALPS. This program is now having physicians and surgeons and other therapists, and it's kind of, and patients, of course, and it's an interdisciplinary bridge to trying to develop the next generation of men and women with an interest in caring for the high-risk extremity. A lot of that is going to be in close liaison with patient-oriented groups like Vascular Cures. It might also be with American Heart. We already have core participation from American Diabetes Association, SVS, and American Podiatric Medical Association. So I'm sorry for this silent, sorry, I should say this soliloquy, but the bottom line is that you're hitting on a point that I think is really, really important, which is that no one really owns this right now. But what we need is to bring the folks that care about this problem together, because there are a lot of people that are saddled with this problem. Obviously, Steve and every other patient with this, the hundreds of thousands of people at any given time, most importantly.
David, can I ask you, is it a tactical error to focus on those with advanced disease because the numbers don't help us, when we're trying to garner attention, as opposed to primary prevention or the early disease?
Isn't that a good question, Aruna? I guess I don't know the answer to that, but the thing is that I guess we're all, whenever you're setting up a team, of course, it helps to focus on these, it helps to focus on the problem that's most acute, because as I think human beings, we're better at attacking urgent things than we are at chronic things, aren't we? So you start with this acute on chronic problem, which is what we end up doing when we start these limb preservation teams. But the most important part of this, as you said, as everyone has already said, everyone from Jason to Kevin to Steve and you, has been that it's really getting out into the community and working with people early on, where we can have a lot more medical and even exercise-driven therapies that may be promising for prevention, rather than just urgent reconstructive surgical or endo kind of options to treat these folks. So I guess the answer is it's both, because it's easier in an individual unit to do the urgent stuff first, like an emergency department kind of philosophy. But if you're doing it in a community, you need that community bit. The trouble is that when you cast a wide net, you don't catch as many. It's harder to apply all the resources to get out that broad. I'm sort of not articulating this very well. Forgive me. I'm sort of disarticulating it. So, but there you are. This is like adult daycare for me. Thank you. You're taking me from a crazy, like a Zoom-based clinic right now. So I should be thanking you.
Kevin, I know I'm sort of monopolizing this, but Kevin, I do really want to hear whether prevention pays, or is it the treatment later on? What in your health system is, you look at, clinical performance, and is it, long-term, is it, what pays? What are the economic factors? Is it better to identify someone early, or to, in terms of the economics of it and reimbursement? How do payers think of this?
I mean, I think that depends on where you sit, right? In that whole perspective, but definitely, kind of within our care delivery organization, we at Optum, we have, clinics in many states, as you know, and we've got, we have fully capitated risk for at least 1 million people across the country. So in our model, health is better. It pays to, it's a win-win to me. I mean, it's a win-win because you keep the patients healthy, you keep the providers happier. It saves money. That's where the profits are. I mean, that's just the truth. The profits are in health and not in sickness from where we sit. So
can I ask a follow-up to that to you, Kevin? Again, with my commercial lens firmly in front of my face. So we're in the middle of a clinical trial on a novel med device. I'll leave the commercial out and instead say that in parallel to that efficacy and safety trial, we're also beginning a cost effectiveness trial. We're going to look at qualities and we'll evaluate quality of life using WRQ and other functions of that from your seat and Optum. How important is that? Like, as we bring novel technology to the market, I speak, for BARD and Medtronic, for everybody. Yeah. How important is that in your evaluation moving forward?
Well, I mean, I think the company as a whole is always looking at technology and looking at different things that could improve efficiency at the patient level or improve outcomes at the patient level. I mean, there's, Optum has a venture arm, UHG has a venture arm, UHC has a venture arm. So kind of everything within there, they are always investing and buying companies and looking at different technology pieces that could improve outcomes. So I think, but, I'll give another example though of something like screening for heart failure. And, one of the questions was, should we be doing a BNP on lots of people because it's entered some of the guidelines, right? To check a BNP on certain people to see if they have heart failure. And it's based on things that were done largely in Europe. And, one of the arguments has been that that's not cost effective here in the United States because they checked a BNP in Europe and they were able to catch heart failure early and perhaps reduce mortality or reduce events, but that was dependent upon them being able to see a cardiologist with a very high level frequency and to get echoes on a very high level frequency. They were just doing them over and over again. And in our health system, that is not cost effective. And we're just not set up that way. So there are some things where I would say, yes, you do want to be more aggressive and be more cost effective, but anyway.
So I'm going to jump in because it's our panel and you can't stop me. I have a question I really want to ask because we are always thinking about, as an organization, what's the low-hanging fruit that nobody is paying attention to? Because for this to really work, right, there are so many different players who need to be aligned, right? You need policy, you need providers, you need patients, you need public education, you need provider education. Those are massive lifts. And I'm sitting here wondering, and this relates to a comment that Dr. Conti made a few minutes ago, is screening a potential part of that low-hanging fruit? Is there a major impact we can make that's relatively short-term compared to other, say, for example, massive public awareness initiatives? And if so, I'm going to go find some money to do it.
Yeah, I can definitely take that. I mean, I think, we are in the midst of designing a screening trial, an ABI screening trial in high-risk patients, in particular in minority patients, because those patients often go undiagnosed and they don't receive the benefits of the therapies, some of the therapies that we've been talking about. And, it may seem like a low-hanging fruit, but to demonstrate efficacy of screening, you need a ton of patients. I mean, the sample sizes you need to convince the USPSTF, which is who we need to convince, it's like on the order of 40 to 50,000 patients. And that may be an easy lift for a group like Optum to do on their own, but for a general population, it's pretty hard to achieve that recruitment and timely results reporting. But I think what you all know, and maybe Megan, you actually sent me, was the legislative effort on the Hill right now to try to get reimbursement for ABI screening, and whether it's sort of a moonshot to get that done. That would bypass all the clinical trial evidence. It would go straight from Congress as a mandate to CMS and Medicaid to do this. I think there are many of us that believe that Congress shouldn't be dictating medical care, but that certainly would be the expeditious way to get this done, absent large clinical trials, which take time to conduct. So I'm not sure if that's low-hanging fruit, but it's worthy, because we're not going to get organizations like USPSTF that have so much power to change without that kind of evidence.
I do think you make a great point too about the role of government in some of this, right? Even if you look at CMS and what they will and won't reimburse, and where, site of service, where they'll reimburse and how they'll reimburse, it really does in many ways drive, I think, patient preference. But where a patient goes, what gets done, in many ways, CMS has a pretty large footprint on that decision. ABIs is a great example, right? In some places it's reimbursed, in other places it's not. Some technologies, and I'm not in the ABI business, but some technologies get reimbursed, some don't. And I think, we do need to continue to look at the role of government in all of this as well, because they do have a strong voice in the directions you guys can go. I mean, at the end of the day, a business like Optum is in the business of patient outcomes first and foremost, but secondarily, as Kevin was just alluding to, he can't do that at a place where it's a losing money proposition in perpetuity. Nobody can keep their doors open in that environment.
I want to also comment. I participated in a discussion with CMS about reimbursement and for screening ABI and actually it was for diagnostic ABI, and to get a more nationwide standards. There's a name for it, and I can't remember what that name is on the top of my head, but it's a standard for the MACs to reimburse the Medicare MACs to reimburse diagnostic ABI. And I really felt from that conversation that one of the key problems was that they were afraid that if we make it too easy to get these tests done, that it's going to drive interventions, that is going to be a huge cost and maybe unnecessary interventions. So as I think has been mentioned, there are many partners, participants in the conversation that have very somewhat polarizing opinions, and to protect their individual interests, especially in PAD. So we have to have clinical trials that demonstrate, in my view, clinical trials that demonstrate a huge benefit. So it's unrefutable that there is a clear-cut benefit to patients from the types of things that we're asking Medicare to reimburse.
Kevin, I'd love to know your thoughts on that, on the impact of screening in terms of costs and outcomes.
And so again, I think it depends a little bit. It depends a lot on where you sit. We have done extensive screening. I mean, we have screened millions of patients in the past 6 years, probably, and definitively, that's the question that always comes up. The question always comes up is, well, you're going to screen and you're going to end up with a lot more cost because there are going to be so many more procedures, and we just don't see that. We haven't seen it anywhere. In any of our care delivery organizations, we haven't seen, we haven't seen an inappropriate uptick in procedures because we're screening for peripheral artery disease. But we may, hopefully we may get better at smoking cessation, exercise, statin utilization. I think those are some of the places that we're looking now. But if you're in a completely fee for service world, I mean, I can definitely see where some of these screens may lead to referrals, which may lead to procedures, which, I mean, may or may not always be the best thing. I mean, we've got Steve right here, who was recommended to have a procedure and then got a second opinion and did exercise therapy. And so I think it depends on where you sit. But where we are holding risk, no, hasn't been an uptick in procedures.
So we're at time. I'm going to pop back on and just give the opportunity for any final comments from panelists or from the audience. And we'll wrap up.
Yeah,
Where do
I'll
we go
just
from
close
here?
out. Yeah, I'll close out for me and just say, first and foremost, thank you so much for the opportunity to participate in this. Great panel. It's really an honor to be spending some time here. And I will just tell you that in all sincerity, I think industry takes its role in this very seriously. We see ourselves kind of straddling things sometimes. And so we want to continue to take our direction from all of you, from Steve on the patient side, and then obviously from our physician and administrative partners as well, to understand how we can best continue to help drive awareness of PAD, and to the points that I've seen in the chat and that the panel has made. Also, how do we get to this sooner? Which is clearly one of the big takeaways that I take from this panel, is that if we're waiting until you're symptomatic, we're just too far down the path, and we need to figure out a way to integrate sooner. So thank you. I greatly appreciate it.
Thanks, Jason.
Thanks. I'll say probably that one of the biggest takeaways I've had from this conversation, I come from a purely data science and population perspective, but what I'm hearing is that there's a lot of concern about how we get therapies to patients, and how do we convince payers and governmental agencies to support those efforts. And I am going to go back and think about what I can do from my own side to help make those arguments, because I do think in the end, the data is what will precipitate change. So I too thank you for inviting me to the panel. It's been really a pleasure.
Thank you. I gave Mike Conti the ability to talk, which is always dangerous, but I think you have a specific question for Kevin.
No, I think this panel has been great. So thank you all for doing this. I just, wanted to come back around to what do we do once patients know, once they own their vascular health, or they are identified as having an issue, but it's, relatively early in the disease. What are the next steps? And I think if we don't fill that blank in, for example, provide them with some sort of access to an exercise program of some kind, then it becomes, it's in some ways, like you said, Kevin, A1C is kind of just a number out there. But I know if I do X and Y, I can make my number better. So hypertension is a number. I guess if I take my meds, I can make my number better. How do I make my PAD score better, or my PAD risk better? We need to provide them with tools to do something with. And right now we have a problem that supervised exercise is approved by Medicare, but in the United States, we have inadequate access to, even in San Francisco, to actually prescribe it anywhere where it can be done. So how can payers incentivize closing the loop on this, which will undoubtedly result in fewer hospitalizations and procedures down the line?
Yeah, and I think that's a no. Go ahead, Steve, please.
Oh, no, I'd just like to thank everybody for allowing me to participate. I in the notes here, I saw some of the comments from Dave, who I have a great admiration for. I always think of him when I see things that he's put on LinkedIn, about some of the conditions in your feet, and that's another kind of thing that influences me to keep walking. But I think the point that he made there, and I think from the patient perspective, I continue to kind of add that I believe these Facebook groups that are growing with regard to PAD are great audiences to be able to connect with and give feedback to, beyond a lot of the things that have also been talking about today. I think the screening that Dr. Conti brought up, if I'd been screened when I was at the time running and I was feeling a condition in my lower legs, I would have known at that time that I had a blocked artery in my right leg. And that was like 20 years ago. So anyway, that's my 2 cents.
Steve. Kevin, why don't you wrap us up?
Yeah, okay. I will say to Mike, I think you bring up a really interesting point though about objectivity, because a patient can be told to, here's how you can control your blood sugar better. And they can be told their A1C went from 7.5 to 6.2, or they can be told their blood pressure went from 155 to 135, or their weight went down by 15 pounds. But there's really no measure of success that they can see, that the patients can see right now when it comes to exercise. And you think, so if you walk 7,000 steps a day, what impact does that have on outcomes, and can we make it measurable? That's a really interesting thought to me, and maybe that's something for more exploration. But
it's your next challenge.
Yeah,
I think if you bring all these tools together, you get back to the information thing though. I can see my A1C go down if I'm being even more active in the summer and, of course, following my diet. But again, that's being able to access different information that I'm able to get access to. And I think more and more we will be able to get more access to more information to reinforce some of the behaviors that we need to put in place as a PAD patient.
well, and that's patient empowerment right there, right?
There we go. The perfect ending.
Yeah.
Thank you so much, everyone, for joining, and thank you to our panelists. This has been fantastic. As always, we will do our best to take what we've learned here today and turn it into practice that can benefit others. So thank you all, and hopefully we'll see most of you in an hour or so for Circulate. And if not, take care and be well.
Thanks, everyone.
Thanks all. Bye-bye.